Dr. Blagg will always be known for his contributions to nephrology.
Chris cares not only about clinical medicine, but about the political environment around medicine.
Dr. Christopher Blagg was among the first researchers of kidney dialysis. He worked closely with Dr. Belding Scribner, who developed the shunt that made life-saving maintenance dialysis possible.
The Seattle Artificial Kidney Center was the first out-of-hospital unit in the world. People came from all over the world during the 1960s to meet with Scrib, to meet with us, to see how we did things.
Dr. Blagg went on to lead the pioneering organization now known as Northwest Kidney Centers for nearly 3 decades.
When he first got involved in dialysis care, he had the vision to see that it could go a lot of the way to restoring people's lives.
Dr. Blagg is one of the most passionate people I know about kidney disease research and treatment.
Dr. Blagg has published over 300 papers and book chapters, and he was editor of Hemodialysis International for 7 years. His commitment to patient care and public policy has influenced generations of physicians and now inspires all who attend the annual lecture named in his honor.
The Chris Blagg Lecture is an opportunity to address the political issues that impact on medical care today.
He was such a pioneer in the field. He's been an inspiration to many, many nephrologists.
Hello, everyone. Thank you for joining us for this late day session. This is the Policy in a Post-COVID World session. I'm one of your co-moderators, Dr. Jeff Perlmutter. I'm a community nephrologist in Rockville, Maryland, near Washington, D.C., and president of the RPA. My co-moderator is Dr. Michelle Josephson, who's a professor of medicine at University of Chicago and chief of the Medical Transplant Service. There, I would like to extend my thanks to the ASN for maintaining the tradition of the Blagg Lecture, which has always, I think, been a very important part of the ASN meeting. Our first speaker, just a bit of housekeeping. We're going to have Q&A after each speaker if you so choose. There's something specific to one of the speakers, and then all of the speakers will be on for a panel discussion at the end. Our first speaker is Dr. Nicole Lurie, who is the strategic advisor to the CEO of the Coalition for Epidemic Preparedness and Innovations. She's also a senior lecturer at Harvard Medical School, a member of the research faculty at Mass General, and a professor of medicine at George Washington University School of Medicine. Dr. Lurie got both her undergraduate and medical degrees from the University of Pennsylvania and did all of her training, including in public health at UCLA, period. During the Obama administration, she served as an 8-year term as Assistant Secretary for Preparedness and Response at the U.S. Department of Health and Human Services. In that role, she led the HHS response to numerous public health emergencies, ranging from infectious disease to natural and man-made disasters, and was responsible for many innovations in emergency preparedness and response. She also chaired the Public Health Emergency Medical Countermeasures Enterprise, a government-wide organization ultimately responsible for the development of medical countermeasures, including vaccines against pandemics and emerging threats. So you can see why she is a very apt speaker for today. Her research has focused on access to and quality of care, health system redesign, health equity, mental health, public health, and preparedness. She is a recipient of numerous awards and is a member of the National Academy of Medicine. She continues to practice clinical medicine in a community clinic in Washington, D.C., and she's going to speak to us about kidney care and the COVID-19 experience. Dr. Lurie.
Great. Thanks so much for having me to this really important lecture, and it's just been a pleasure to be working with ASN on emergency preparedness issues over the past couple of years. So I'm going to speak a little bit about kidney care in the age of COVID-19 and just want to offer a couple perspectives first from my experience doing disaster management for so many years, and begin by observing that as challenging as this period is in our lives, crises can also bring out the best in people. And one of the things, in fact, I've seen with the kidney response and with ASN, in fact, in many of our communities, is just how much, in fact, it has brought out the best in people, despite the fact that it's easy for us to focus, I think, on the negative. But to say first that from my experience, any response to any crisis is built on the back of a day-to-day system. And if your day-to-day system is strong, you're going to do better than if it's not. COVID is no exception. I'd say additionally, nothing follows the playbook, but it really helps to have one. And in fact, there were numerous playbooks, I think, ready to be used at the start of this pandemic. But I would say that if you could do the core functions really well, whether it's in a public health response or whether it's with regard to kidney care, then you have the mental space and the agility to adapt to new situations. And then my final observation might be, never let a good crisis go to waste. This is really the time for us to be thinking about the way we want the world to look and the way we want kidney care to look going forward. So I'm going to talk about 4 main themes today. The first is make a few comments about leadership. The second will be about day-to-day systems in kidney care. The third is I'm going to comment on a number of the equity challenges that we've seen throughout this pandemic. And finally, I'll talk a little bit about innovation and what ought to come next. So having played a number of leadership roles, both in and outside of government, my first observation, I think, is that leadership can come from many places. In fact, it can come from just about anywhere. We often think about it as an attribute of elected officials. It can also come from really strong local leaders. And certainly in this pandemic, we've seen lots of local leaders. We've seen a number of governors really step up and exhibit exemplary leadership. But it can also come from frontline caregivers. And I think in many of our institutions, in many of our hospitals, and many of our dialysis facilities, we have really seen frontline caregivers not only be heroes in the caregiving sense, but really step up and lead. And I really salute them. I would say for leadership, authority is helpful, but it's not essential. And again, we've just seen many people without any authority whatsoever quietly go about organizing people, quietly go about organizing what's needed to be done or what's needed to change. And that has just been absolutely critical. When it comes to kidney care, I think the kidney community has experienced what many others have, that there's been no national plan. But I think unlike a number of the other areas of medicine, the kidney community has really, really stepped up. And just want to say, for those of you who really don't know it, ASN has played a really pivotal role in bringing together a number of organizations within the kidney community. And you should feel really proud of this organization for all that it's done. Strong day-to-day systems are absolutely essential. And I guess, again, from my perspective in crisis management like COVID, having those strong day-to-day systems really help you pivot in a crisis. So what have been some of those day-to-day systems and day-to-day recognitions that have helped us so much during this crisis? First, I think there has been now historically really good recognition that ESRD patients are vulnerable to any kind of disaster. There's been a huge amount of focus in disaster planning, in particular on dialysis continuity, especially during times people are displaced, like during hurricanes and tornadoes and floods. And there's been some planning for acute kidney injury, such as the kind we might experience in an earthquake, and the kind, in fact, we did experience during earthquakes in other countries, whether in Haiti or Nepal. And I know probably a number of you watching this volunteered or were involved in some of those responses. And, I think it was getting ready for thinking about how you surge in acute kidney injury that in part was really helpful when acute kidney injury was recognized as such a complication of COVID. So the early recognition of the dialysis challenge for COVID staff and for COVID patients and the staff taking care of them has been really important. And I would say there are a number of day-to-day systems that have helped with that. As I commented on, multiple emergency response plans, whether for federal level, state level, local level, for hospitals, for dialysis companies. This is one place where the kidney community really seems to have it down. It's got a good emergency response plan. In addition, I think during the time that I was the assistant secretary, we built a system called Empower, which used CMS Medicare data to identify every dialysis patient, be able to put them on a map, and to be able to let state and local officials know in a disaster who they were and where they were, in case they didn't know, so that they could get them out of harm's way. That and some other sorts of things, and lots of disaster experience really created in HHS, in the Office of the Assistant Secretary, core career staff who deeply care about kidney patient issues and who are deeply skilled in how to deal with them. And I think in a couple minutes, we'll talk about an example of how that's really come into play as a strong day-to-day system. This community has a really strong CMO network, and in many cases, strong regional organization. And between the CMO networks and the dialysis companies, people are used to talking with each other. They're used to dealing with important issues. And so when a crisis came their way, they just stepped up and did what they needed to do, use the CMO network and others to try to solve problems. About a year and a half ago, ASN started an emergency preparedness initiative, and in fact, asked me to lead this with Jeff Silversweig. And a lot of the planning was what we would do in cases of various emergencies. It was really planned in the aftermath of a number of hurricanes, but a lot of the planning and sort of the core infrastructure about how we would respond in an emergency really enabled that group again to stand up when we started hearing that there were challenges, particularly for dialysis patients with COVID, needing to continue their dialysis. There's been a lot of work on crisis standards of care and on workforce planning, again, for emergencies. And that workforce planning and those crisis standards planning, again, have enabled this community in particular to really excel when it's come to think about surge staffing. And finally, the focus on safety and infection control in the kidney community and the dialysis community had really created the linkages, I think, that help people get ahead of this whole set of issues really early. And all of these day-to-day systems enabled folks to pivot in a crisis. In some ways, I think this pivot and these networks and the resultant leadership within ASN really pushed the government to take action in a variety of areas, whether it was providing guidance early on about how to safely manage COVID infected or COVID exposed patients in dialysis facilities, to a situation, for example, that you might have heard about from some of your colleagues, which was really that over Easter weekend in New York City, a number of hospitals started really informally reporting and notifying colleagues that their hospital was out of dialysate fluid for taking care of acute kidney injuries in the hospitals. And, within a relatively short period of time, again, through this emergency preparedness network and the CMO network and others, people got together, they looked at the problem, they documented it. They actually got in touch with HHS and found their way to these core staff who really were deeply experienced in dealing with kidney issues. And working together, they were really able to solve the problem. So it's really a testament to the organizations and the relationships that people have been able to build. Let me shift for a moment and talk a little bit about some of the equity issues that have arisen from COVID, because it's fair to say that for, I think, so many of us involved in one aspect of this crisis or another, race is really the elephant in the room here. the excess mortality in Black, Latinx, and Native American populations has been absolutely staggering compared to white populations. And this has really coincided, as I think we all know and appreciate, with what has become a very challenging, often very emotional national dialogue about race, about racial injustice, about structural inequality, and about racism. And it's made us have to confront a lot of these issues in very important ways. And the medical community and the kidney community in particular have really needed to confront these issues, some of which have been overt because of amazing leadership within ASN. And it was great just to see Neil Poe in that video. And also some of them some of it has still been a little bit under discussed. But I think for me, it not only points to the kinds of structural inequalities that we see in our society that have put so many people of color in the path of COVID exposure, whether it's because they're frontline workers, because they have to take public transportation to go to work, because they can't telework, because they may not have good access to testing, because many people live in crowded or multi-generational households, all of those kinds of things which have to do with the structure in which our society is put together. But for me, it's also pointed to some real underinvestment in the science about how it is that structural inequality and structural racism makes you sick, including in the kidney community. I think about some of the things that might be a little bit of our own institutional, I won't say biases, but ways of thinking that we've taken for granted for a long time, such as questions about race and EGFR and other kinds of things that have made us take for granted maybe for a long time that some of the race differences that we see are just differences that we see, and there's not much we can do about them, we just accept them. And I think it's caused all of us to really question whether that's really the case. So the kidney community is really at the leading edge of this dialogue in medicine, and I think it has the opportunity to continue to lead. And it can continue to lead in thinking about how to work upstream, how to think about preventing the conditions that cause renal failure in the first place, how to prevent progression, how to get us to equity in transplantation, how as home dialysis rolls out, we get to equity in home dialysis, and ultimately how we get to equity and access to new technologies. These are all really important questions, I think, for this community and this organization to take on. How is it, in fact, that you can leverage the institutions you work in and your communities to understand and impact more of these factors where your patients live and work? One of the things that for me has been a really interesting observation about the nephrology caregiving workforce is, on the one hand, you've got the physician community, largely white, very disproportional underrepresentation of Black, Latinx, and Native populations in the nephrology community. If I look at the frontline dialysis technician workforce, it's kind of flipped. And we can ask ourselves lots of questions about it, but we can also think about whether now there are ways to have some intra-professional, intra-workforce learning, I guess I would say, about what are the kinds of conditions and communities that make people sick, and how we as kidney physicians in particular, or physicians and nurses, might in fact leverage our institutions to think about working on those more. And we can talk about that, I think, a little bit later during the Q&A if you want to. Finally, I just want to make a few comments about my comment about never letting a crisis go to waste, and about innovation. Because I think COVID has required all of us in medicine and all of us in the kidney community to have to innovate in ways that we never have before. And that provides a number of opportunities for us. So nationally, one of the things that's happened with ASN standing up and talking to folks at HHS, both about emergency preparedness in general, and about COVID is that they've asked ASN to sort of serve as a one-stop shop for HHS with regard to kidney community needs in a disaster. So how might we now think about this relationship as we move forward with moving to get ourselves out of this awful pandemic? Well, one of the first things that comes to mind is that right now, HHS, ASPR, has every dialysis patient in the country, in fact, probably every kidney patient in the country, on a map. They know how many are in each community. And this patient population has almost the highest mortality from COVID, and they will be at the top of the priority list for vaccination. So rather than just leaving it to the system as it might be, might we think about pushing them to use those now day-to-day systems they use to get people out of harm's way in disasters, to think about how to notify those people and their state and local health departments and everybody else to come in and get vaccinated once vaccine is available, for example. We've seen a ton of innovation moving toward telehealth and remote monitoring. And I think we are really poised now to think about this innovation, to think about how might we accelerate prevention of kidney care using these remote technologies? How might we really step up preventing acceleration of disease using these remote monitoring technologies? There's a lot to do there. How could it accelerate a move toward home dialysis? We've already seen that happen, but happen mostly for patients who know about home dialysis and have the means to try to get it and to get themselves out of dialysis facilities, which they feel are dangerous during this difficult period. It's not happening with any equity at all, but it could happen and could be accelerated because of what's going on with COVID. I was thinking as I was watching the video about Dr. Blagg and reading some of his earlier publications about whether home dialysis is actually an innovation, and thinking back now to my own experience as a medical student in the, maybe 1977, I went and did a rotation in a small coal mining village in South Wales in the UK. And this was a community in which there was a GP who was very, very focused on obsessively tight blood pressure control for hypertensives, obsessive glucose control for his diabetics, and doing everything he could, even then, to prevent the progression to kidney disease. But he had one patient that was on dialysis, and that patient was on home dialysis, hooked up to his kitchen sink. And this was 1977. I fast forward to now, where I visit an Indian reservation where there are 75 dialysis patients, and none of them are on home dialysis or even get dialysis on the reservation because there's not stable access to running water. Back in medical school, I thought home dialysis was around the corner. It's still around the corner. How many years later? It's not exactly an innovation. The technology is certainly a whole lot better, but we need to speed these innovations to patients, and then we need to be thinking about the new care models for these patients, both day to day and frankly in a disaster when they're all going to need battery backup when the power goes out. There's opportunities to think about how we innovate here in mental health. And again, ASN and the kidney community, kudos to them. They have stepped up and really thought about the mental health issues for their providers and their patients. But it provides opportunities for us to innovate in mental health and prevention in mental health around the country. It allows us to innovate in social policy for disasters overall, whether it's about paid sick leave or unemployment or any of these other things, should we ever have a crisis like this again. So how should we be supporting innovation as a kidney community? It's interesting to me that in the preparedness space, we support innovation in part by investing in what we call countermeasures, but technologies, vaccines, therapies, diagnostics for a disease that we're not even sure exists and might never come. How do we apply that kind of thinking to invest in innovation and understanding kidney disease and the applications of science to improve kidney disease and kidney care? How are we going to innovate in addressing racism? And finally, how is it that we want now to create the world that we want to see for our patients, for ourselves as clinicians, and for our society overall. So let me close just by two last comments. First, let me go back to my role co-chairing this emergency preparedness initiative for ASN. And I want to turn the tables and ask all of you, in the innovation sphere or in the response sphere, what should we be doing on your behalf and on behalf of the kidney community to be helping to pivot to create the world that we all want to see? And finally, it's not lost on any of us, even if we might want to forget it for a moment, that we are 2 weeks from an election. And I think all of us, and I hope that you will all, empower your own patients to think about having their voice heard in the future of their medical care, and please to encourage them and help them to vote safely. Thank you.
Thank you very much, Dr. Lurie. We're going to have one quick question for you. There is a second question. It's quite a bit more complex and not necessarily apt for you, that will hold till the group Q&A. One of the attendees did want to know what you meant by the CMO system.
So there are a group of dialysis chief medical officers across the country that have their own sort of sub-organization or their own organization in some sense, but and they get together on a regular basis and they talk about issues in kidney care. And they've gotten together, those CMOs have met every week, I think, since this all started. And it's been quite impressive to see.
They've been meeting for years, you're correct.
Yeah, they have, but they've stepped up and really, you know, taken on, they've shared issues, they've taken on a lot of issues, they've gone to CDC, to CMS, to others to help solve those problems, and they've shared best practices with one another and with the community.
Okay. And I'll hand it off to Dr. Josephson.
Okay. Well, thank you, Nikki. That was fabulous. We're going to move on now to our second set of speakers, the Klotmans. It is really a pleasure for me to introduce our next speakers, the Klotmans. Mary Klotman is the Dean of the Duke University School of Medicine and Vice Chancellor for Health Affairs and Chief Academic Officer for Duke Health. Prior to her appointment as Dean, Dr. Klotman served with distinction as Chair of the Department of Medicine in the Duke University School of Medicine for 7 years. Dr. Klotman earned her undergraduate and medical degrees from Duke University. She completed her internal medicine residency and a fellowship in infectious diseases in the Department of Medicine at Duke before joining the faculty as Assistant Professor of Medicine. She joined the National Institutes of Health in 1987, where she was a member of the Public Health Service and trained and worked in the Laboratory of Tumor Cell Biology under the direction of Dr. Robert Gallo. In 1994, Dr. Klotman joined Mount Sinai School of Medicine, served as Chief of the Division of Infectious Diseases for 13 years. She was also co-director of Sinai's Global Health and Emerging Pathogens Institute. Dr. Klotman's research interests are focused on the molecular pathogenesis of HIV infection, particularly the role of the virus in HIV-associated kidney diseases. Most recently, her group has been defining the role of integrase defective lentiviral vectors for the delivery of an HIV vaccine. Dr. Klotman is past president of the Association of American Physicians and past president of the Association of Professors of Medicine. She was elected to membership in the Academy of Medicine in 2014. Dr. Paul Klotman is president and CEO of Baylor College of Medicine. He received his MD from Indiana University and completed his internal medicine residency and nephrology fellowship training at Duke University School of Medicine, where he met Mary. After fellowship, Dr. Klotman stayed on at Duke as faculty till moving to NIH, where he went on to become chief of the Viral Pathogenesis Laboratory. Following his time at NIH, he moved to Mount Sinai School of Medicine in New York as chief of the Division of Nephrology. He went on to become the chair of the Department of Medicine. In 2010, Dr. Klotman was recruited to Baylor as president. Given their career journeys, expertise, and combined experiences, I cannot think of two better individuals to give the next presentation entitled Footing the Bill, reliance on private institutions to address health crises. Please join me in welcoming Mary and Paul.
Thank you, Michelle and Jeff, for inviting us tonight. We're going to tell our own institutional stories about the partnerships, the new partnerships we forged between our institutions and our communities in managing this crisis. But I can also be assured that the stories we're going to tell are stories we hear from every academic health system. I think the willingness and ability for so many of our faculty and staff to step up way beyond their day jobs has just been extraordinary. And it has been necessary, actually, to fill in gaps in much needed resources and expertise to manage the pandemic. And while the stories are somewhat of a silver lining, I think they've exposed some real challenges ahead. And hopefully we'll use this opportunity to learn and be better prepared for the next crisis, which, as Nicole said, undoubtedly is going to happen. We're just not sure what it will be. So I'm going to talk about what we've done in the Durham community, and Paul's going to talk about what Baylor has done in the Houston community. So if you think about academic medical centers, the AAMC has been really a terrific advocate for codifying the data that really explains why academic health systems are different from other health systems, best equipped to care for the sickest, most complicated patients, usually serve as medical safety net for communities, and COVID has highlighted that, responsible for educating new generations of healthcare professions, and also responsible for driving the research engine and to transform medicine and potentially play a leadership role in reforming healthcare. So next slide, mine aren't advancing. So if you think about those major roles of academic health systems, obviously COVID and our role in actually managing COVID has been critical. So certainly in terms of taking care of the sickest, most complicated patients, COVID patients that end up being hospitalized require some of the most technically advanced care in our ICUs, and teaching hospitals are really treating the most complex COVID patients. And our communities have really relied on us to care for a disproportionate share of patients who are suffering from a lot of the social determinants of health. And as Nicole noted, this pandemic has been striking in terms of really showing us healthcare disparities that exist in our own communities. We certainly have continued to take on the responsibility for educating the next generation. Very often, we have pivoted overnight into virtual education so we could keep the training process going, and pivoted our research to really focus on COVID in so many ways. But what I'm going to talk about is not those traditional roles of our academic health systems. They've been incredibly important for managing COVID. But the other aspect of the work, which are these partnerships that really developed overnight to solve problems in a real-time basis, problems in our community, either local or at the state level. And that's the work that has really been driven in each of our communities by the needs of our communities. And so if I think about the next slide, please, if I think about the buckets that work fits in, one of it's providing critical expertise, again, at the local level, state level, regional level, national level, international level, infection control, basic medicine, behavioral health, data science. I mean, the data science community has been incredibly effective in bringing online tools for us to be able to manage the crisis within our communities. Certainly biomedical science and really operations. We have been partnering for testing, safety, vaccine policies, protocols, logistics, and innovation. And in the media, very many of our faculty have become trusted sources of truth. And Paul, I think, can talk extensively about this in terms of his faculty. And then there's just a myriad of community projects to fill in the gaps and meet the needs of our community. Next slide. So when I thought of my own faculty, I just did a very rough survey to really codify the roles that they've been asked to and willingly have taken on to provide their expertise and thought leadership. And the list goes on and on. It's everything from being members of task force and how to open up safely, helping schools open up safely, advising our skilled nursing facilities, working with our fairly vulnerable populations, to working at, next slide, the state level, where our Department of Health and Human Services has really asked many of our faculty to become formal members of their various task force, whether it's figuring out vaccine distribution or figuring out policies around safety, the phases of opening. Next slide. And then it's a regional and national and international. So, at one level, this type of work is not our normal daily operational work, but it's been so critical in advising our communities on how to move forward and how to do things safely. Next slide. Another critical role of our faculty, I actually don't have a slide on this, that I did a survey around, was the role of our faculty in informing elected officials. And I think this has been a wonderful partnership where either at the North Carolina level or at the national level, faculty have been asked to join various groups to just inform them and keep them up to date on both the science and complexities of managing through COVID. So now I'm going to talk about a few of the projects that I have been following, and this is all driven by faculty. This is not driven by a dean telling faculty what to do. So one big area, I think, where we've identified gaps in almost all of our communities are the gaps in resources and expertise needed for schools to make informed decisions. Now, if you're at a university like I am at Duke, internal to Duke, we have readily been part of the decision making at the university and really been partners in making those decisions. But I'm talking about the primary and secondary schools in our community that really were left sort of on their own to figure out, how do I make this decision? And if I do make a decision to open a school, how do I do it safely? So two of our faculty in the Duke Clinical Research Institute, and both members of the Department of Pediatrics, Danny Benjamin and Kanisha Zimmerman, started something called the ABC Science Collaborative. And this is really a partnership with our community leaders and members of school boards and leaders in various school systems to really work together to understand, first of all, the data at hand, to help them make informed decisions about when and how to open their schools. And then when they start opening their schools, how to do that as safely as possible. This has now touched almost all of the school districts in our area, and the hope among Danny and Kanisha is that this goes national. Another area where there's been very significant gap, next slide, is really providing support to some of our most vulnerable communities. So in Durham, about 10% of our population is Latino, and yet over 40% of our confirmed COVID positive cases where we can identify race and ethnicity are Latino. And yet we really didn't have an organized infrastructure in testing, in providing the necessary education materials. So two of our faculty organized something called the Latin 19 Latinx Advocacy Team and Interdisciplinary Network for COVID-19. And this team works with community leadership, again, first to help understand the data in our own community, to generate education material to be disseminated among the community, and to really advocate at both the local level and the state level to get the resources needed. So one of the good examples was actually advocating for a mobile testing unit, which goes from community to community. This group now has grown in influence to the point that Viviana now is a member of the state task force and on loan to the state to really help the state think about how to engage their most affected communities going forward. Next slide. Another big area of work has been the area of policy. So before COVID, we have a Margolis Health Policy Center, and it's probably been in its about third year, and COVID hit. They completely pivoted to almost all of their efforts focused on COVID, developing policy at the local, state, and national level, everything from initially how to start reopening safely to policies around how do you both mass generate therapeutics and vaccines and how do you distribute them. So again, a good example of an effective public-private partnership. It's under the leadership of Mark McClellan, who is one of those faces you see on the news almost as much as Peter Hotez, who Paul will talk about, but really to a credit to the credibility of the policy center in really thinking through some of these complex challenges. Next slide. So as we go forward, next slide. We wanted to try to actually track our community initiatives, both to understand where we're having the biggest impact and to provide the resources needed. So the university surveyed our faculty across all the schools. As you might expect, the School of Medicine had the most community initiatives under COVID. If you look at the distribution of the areas of focus, education has been the most common area, followed by community healthcare delivery. And the majority of funding has been through the university and Duke Health. I do not have a number in terms of cost, but I am certain that in the end, when we really look at that, it's going to be in the millions of dollars in supporting these kinds of partnerships. Next slide. So I just want to go through a few of the projects. Each one has been so unique and so focused on an identified need. So the case investigation contact tracking tracing project, if you go to the next slide. This was a project that started in mid-spring when we realized, as many communities realized, that we did not have the workforce to really do extensive contact tracing. And not only did we not have the workforce, that to scale it up was going to take a lot of time and a lot of money. So our director of our physician assistant program partnered with the Durham County Department of Public Health, and together they designed a program that rapidly trained our PA students. And then the PA students with their faculty developed a community health elective course. And so in the process of developing a solution for a workforce to do the tracing, also developed an education program for which the students got credit. And this project was wildly popular among the students. Next slide. So one other area of very significant influence is that many of our faculty have become trusted sources of truth in the news. We, like many of the other institutions, have had our faculty very visible in really trying to educate the public in the science that is so important in driving effective solutions to COVID. Next slide. So this is more to transition to my husband. When we looked at the top news stories that came out of Duke and what the combined reach was, our biggest story was the story that came out of a collaboration between Duke Health and campus on the most effective masks, where the gaiters were shown to be less or actually ineffective. But that was followed by the story of a dog in a family that was the first dog positive case for COVID. So Paul, your use of our dogs, I think, is very wise. People love to hear those kind of human interest stories. So with that, I'll turn it over to Paul to talk about some of the work going on in Baylor and Houston.
Okay, thank you, Mary. As they're putting up my slides, I just want to echo one comment that you both made, Dr. Lurie and you, about leadership. I think there's no question we have had a failure of public health leadership in the country. With this pandemic, it's exposed a lot of problems. And as a result, many of the institutions, the academic medical centers, have had to step up in ways that we never intended or expected to be. You know, public health schools are not combined with medical schools. They're independent. Medical schools have had to really step into the fray, and a lot of the health systems that, you know, big health systems, for-profit health systems, even the large not-for-profits, are not in a position to do the kinds of things that an academic medical center can do. Can I have the next slide, please? So one of the strangest things that happened was the Texas Medical Center, which is the largest medical center in the United States, has over 56 institutions. We see about 10 million patients a year there. We all compete, collaborate, compete. And so the first thing that was really unusual is all the CEOs of the hospital systems, and there's 7 of them, and the presidents of the medical schools got together, and early on, through the leadership of the Texas Medical Center CEO, decided we would share data. And if you think about one of the failures, and in my view, the biggest failure of the public health system for this particular pandemic is we did not have access to actionable data. And so we started sharing our data, and we covered about 80% of the population of Harris County, which is the county that Houston's in, and its 8 surrounding counties. To put that into perspective, there's over 15 million people, thousands of square miles. It's bigger than 30, states. And we started sharing data in real time. And because we were developing all the tests, we actually could follow the pandemic and the local effects of the epidemic very easily. We started daily meetings. It's come down to twice a week. Because we were the source of real data, city and county leaders followed this. It is published daily in the Houston Chronicle, so they get our data and publish it. And the problem was that the state has 600 sources of information. Some of them were the for-profit laboratory testing agencies that were following, weeks late. Many of them were individual doctor offices. And so it was just impossible to collate the data and be able to actually manage it. And so we were the source of real data, and this was really important. And as I said, we met and we would look at the data sets, we would discuss it, we'd argue a little bit, and we created 2 important sets of data, one that we publicly made available, and then one that we made that was really for the CEOs, and that had to do with things like supply chain and ventilator stuff that we didn't think the public should or need to know about. Next slide, please. The other thing Mary mentioned, we all become very important providers of information. The way our community runs, we have a mayor of Houston, which is the 4th largest city in the United States, but we also have a county judge and county commissioners that run the various county districts around the city. And we also have an organization called the Greater Houston Partnership that is the business community. And we provided all the data and information for them in a very nonpartisan, transparent way so that they could make information or make decisions based on really solid information. We also advised the Texas House of Representatives. Many of them hosted us to give these big Zoom meetings. We had sometimes as many as 40 or 50 different representatives on a Zoom meeting to go over these data sets and then ask questions. And we've been doing this almost once a month. Next slide. We also did the same thing for the Texas federal representatives and had a huge number of them, again, on calls. Many of them took the opportunity to host, so like Senator Cornyn would host a group of his colleagues, and the Democrats would host a group of their counties. Congressman Al Green had a big representative group that we would, again, advise and basically give information so they could make decisions. Next slide, please. And then finally, as I think the whole concept of testing was a relative disaster. I mean, the CDC made some missteps in the beginning with the wrong tests. It took too long. They didn't want university labs to be testing in the beginning. The commercial labs wanted the business, but were terrible at returning results. And so the academic centers really stepped up. We are one of the 3 funded NIH genome centers, and we quickly converted to doing PCR-based testing. We set up a test center. We actually do all of the testing for the city, all of the testing for the county. And so you can see down below on the right, the number of tests we did, and then the blue is negatives and the reds are positives. But we became the center for testing. And then the other advantage to that then, of course, is we had the data. So we could be reporting data within 24 hours of tests, and that was critical for decision making here in Houston. And I don't know if you've noticed in the, watching whatever your special news channel that you like to watch, but the slides of how everything's going terribly throughout the country, that's pretty much true right now. Texas is not doing all that great, but it's not in Houston. It's in Dallas County, it's in El Paso, San Antonio. Houston is way lower than the rest. And a lot of it's because of the ability that we have to test. And we've also have a county judge that has put in a mask order and a stay home order that's been pretty extended. Next slide, please. Just go to the next one, please. So one of the coolest things we did working with the city is we tried to do early on, used our microbiome center to begin to do surveillance of wastewater. And so there are 39 wastewater stations in the city of Houston spread throughout. And so we started doing sampling of these waste treatment centers every Monday, collected data, looked for, did the qPCR for virus, did viral loads, and identified hotspots, which you can see on the map of Houston on the right. And that allowed the city then to mobilize their mobile test centers and put tests into communities that were having outbreaks and do a much more extensive testing, even going door to door to test people. And the thing that we've discovered is we can predict in advance of an outbreak about 10 days if you follow wastewater treatment. And this is now being used to do surveillance on facilities like nursing homes or in dormitories and colleges or in communities. So this has been a real advance. Next slide, please. One of the things that we do that's fairly unique is for many, many years, since the 1970s, we have been in charge of a number of STEM schools, magnet schools in the state of Texas. The three blue ones are in Houston, the DeBakey High School for Health Professions, which is the first of its kind, established in 1972, and 2 middle schools, as well as 8 other schools in the Rio Grande Valley. So we provide a STEM curriculum for them. And so we thought this would be a huge opportunity for us to come up with policies around how do you advise school districts around opening of schools and the way to do it safely. Next slide, please. And so because we have this group of people who have been doing curriculum design for these schools for decades, they created a guide to safely open schools, which has been used by all of these superintendents and all the school systems. It gives you a way to start, things to look at, everything from ventilation and what to do for teachers, the vulnerable period for parents. This is put online. There's a thing called Biomed Online that we sponsor, free for everyone. Anyone in the country can use it. We have usually about 500,000 hits on this for teachers and school districts. And this is a guide for public school opening. Next slide, please. We did the same for the business community here. We had 3 or 4 major businesses pilot this with us. We provided a complete guide to how you open a business, what to do with your clients, what to do with your employees. And this has been, again, provided free of charge and online and co-sponsored by the Greater Houston Partnership, that business community group. Next slide, please. And as Mary alluded to, like Duke and everywhere else, we have people who are constantly on TV, being interviewed, trying to provide rational guidance. I'm sure I've seen Peter Hotez on TV more than I've seen him at Baylor. So it's a chance for me to interact with Peter in ways that I've never done before. But besides him, we have many people who are on all the time, advising, even BBC and international channels. Next slide. So that gives you sort of an update of what we do as an institution. I think the main thing we're doing, I hate to say it, is we're filling a void. It's a good thing that we do have academic medical centers. I think it's for the first time in my career as an academician, we don't have to explain who we are. Most, when you're dealing with normal health and health delivery, and we're trying to say why we're good, and maybe your non-academic health centers aren't the same as us. Well, There's no question now. I mean, we filled the gap around information, around testing, around policy, things that should have been done at the federal level and really, frankly, at the state level too. But it has been a really, I think, an important part of the critical mass of response in this country, maybe unfortunately. And I'll be happy to answer any questions.
Thank you for that really excellent overview and of the role of the academic medical center in this crisis. We have really one question that I'd like to ask you before we move to our next speaker. And we actually do have a few other questions, but we'll hold them to the panel discussion. So Deirdre Cruz asked, what have you learned and what new initiatives emerged that you hope to continue at your institutions when we are hopefully, and I think all of us say hopefully, in the post-COVID era?
I'll start. I could go on for hours, but some of the big sort of themes that I've learned, first of all, we can be so much more efficient than we thought we could be in the past. Because whether I'm talking about the programs that I talked about tonight or just our research mission in general, we've been able to get things up and running, work through bureaucracy, get contracts done in a time frame that we could never have imagined. So I think much more efficient and really focused getting things done. I think it has, opened up all the possibilities of what we can do with our communities in such a more sort of a partnership approach rather than the academic institution, being something separate from community, and really figuring out how do we continue to build that, because I think what we have built is significant trust that was not there before, and that's been hard to win, and we need to own that trust and build on that. So I think a lot of opportunities to do things better.
So I'd just add to that the things that for me that were really transformative, and I think we're all will sustain. One is sharing data. And I think we were very reluctant as health systems to share data. I think all of us have seen the benefit of doing that, and all the CEOs have committed to taking some, we've got issues around obesity and diabetes. We need to share data together in ways that we never had. The second thing is telehealth is transformed through this process. 30% of our visits are telehealth. Telepsychiatry is booming. I mean, it's probably 8 times our psychiatry department's finally busy, but it's all telepsychiatry. I think the mental health impact will be huge. And then the third thing I'd say that's really important is, we need to have a voice in American popular health. We're now on TV and interviewing and in the paper explaining complex issues, and the public is desperate for it. We've never really felt that was our responsibility, and I think that's an error in academic medicine. It's all, either we're above it or we don't want to be TV personalities. I mean, the number of times I've been told, "Oh, you don't want to go on TV." I think we got to be on TV more, and we have to be a face of science that's understandable for the public. So those are the 3 big lessons for me.
So I thought I was going to let you off the hook with just one question, but it turns out that Roz Manin has brought up another question.
Of course, Roz.
And this is actually a key, and it's a key question, which is not surprising either. What have been the economic challenges to the institutions?
You want me to go first on this, or you want to go?
Go ahead.
So the health systems, the hospitals have suffered. Every single one, everyone in the United States. Paradoxically, and I'm going to say really paradoxically, and I think this is weird, we've done very well. And it turns out that when you don't travel and you have no place to go and you can't spend as much money as you want, medical schools do better. So we are not dying as many as our hospital partners are. So I think, I think we've been able to come back faster than the hospital systems have. And I think that's true of many of the medical schools. But how about you, Mayor?
Yeah, well, certainly the health system, like all health systems, their FY20 the balance sheet is not good. But I think Duke, just like many health systems, got back up and going. And so far that has been, a recovery that's been quite promising. We're part of a university. Our university has taken a very substantial financial hit. We cut down our number of students back by half, lost a lot of the student fees that support a lot of the infrastructure. We have remained committed, something I'm very proud of, to not furloughing either on the university side or the health system side. But that was a significant financial stress. And the School of Medicine, just isolating that entity, I agree with Paul that the financial stress has not been dramatic. Now, some of that's because the NIH allowed us to keep our workforce on grants. If they had not allowed that, I think it would have been devastating. But that was I think a very wise decision, because it also allowed us to get up and running again very fast with our workforce. We've lost a little bit in some areas that we haven't been able to get up and running, particularly clinical research in the community. It took longer to feel that we could provide a safe environment to do that. But the financial hit to the health system has probably been the biggest hit for us.
Thank you. We do have some more questions, but we're going to hold them to the panel discussion. And I think Jeff is going to come back on and introduce our next speaker. And again, many thanks for excellent presentations.
Thank you, Paul and Mary. It's my pleasure to introduce our last speaker. Dr. Keisha Gibson is Associate Professor of Medicine and Pediatrics and Chief of Pediatric Nephrology in the Division of Nephrology and Hypertension at the University of North Carolina at Chapel Hill. She is also the Vice Chair of Diversity and Inclusion for the Department of Medicine. She's done all her education and training, at least since high school, as far as I can tell, in the Carolinas, with undergraduate at Winston-Salem State University, her medical and MPH degrees at UNC Chapel Hill, her pediatrics residency at Medical University of South Carolina, and then her pediatric nephrology fellowship at UNC Chapel Hill. Her research and clinical interests focus on lupus nephritis and other glomerular diseases. In the area of epidemiology, she is interested in ethnic and socioeconomic disparities and their effect on patient outcomes, including, very interestingly, a research interest in the growing epidemic of chronic kidney disease in West Africa. In the interest of time, I cannot sing all the praises of Dr. Gibson. She's won numerous awards and has served in many capacities in the ASN, but most importantly, she is the current Secretary Treasurer on the ASN Council. I give you Dr. Gibson.
I first want to say thank you to the organizers of this session for the invitation to participate on this panel, particularly with these esteemed colleagues. As I thought about this topic, I thought I'd open with a story about Ms. Nelson. Now don't worry, I have changed her name, so we are all HIPAA compliant. Ms. Nelson is an African-American woman from a small rural town in South Carolina. She graduated from high school, got married, had 5 children, and made a modest living working in food services at a local correctional facility for about 20 years. Fast forward in time, her children grew up, her husband died, and due to her parents' failing health, she moved in with them to function as their primary caretaker. Her father, at the age of 87, was started on hemodialysis and required to be transported more than 25 miles away for treatment. He actually survived almost 5 years on dialysis and died around the age of 92. Her mom, at the age of 91, also developed kidney failure, but given other comorbidities, the family decided against dialysis and she soon died. 2 years later, Ms. Nelson, who lived with diabetes for almost 35 years herself, was now told that she had advanced stage 4, early stage 5 chronic kidney disease, and it was time for her to start making plans for dialysis. She was told, however, that this may be unsuccessful and she may not survive long given her limited vascular access. Ms. Nelson decided at that point to call her niece, who lived in another state and happened to be a nephrologist. She informed her niece that she's had chronic kidney disease now for almost 10 years, but really needed some outside advice at this point. That niece got in her car, drove 5 hours to join her for her next visit with her nephrologist and help advocate for home peritoneal dialysis. The nephrologist at the visit confirmed that they indeed had a home dialysis program, but just really hadn't considered Ms. Nelson a candidate. Now, most of you have probably figured out that this is a personal story. Ms. Nelson was my aunt, and I was that nephrology niece. I remember leaving that visit feeling relieved that her nephrologist agreed to give my aunt a chance on peritoneal dialysis. I knew for her that it would likely afford a better quality of life. But I was also a little saddened that I felt it necessary during that appointment to leap into a discussion about how she really missed her calling in life and could have been a healthcare provider herself, and highlighting things like how she expertly managed my grandmother's congestive heart failure, titrating furosemide based upon her lung exam, and despite my grandfather's advanced age on dialysis, how her care avoided frequent hospitalizations over those 5 years. As I think about that experience, there are a few questions that come to my mind. One, why was transplant never discussed with my aunt during the 10 years she had been followed for chronic kidney disease? If I hadn't been there at that appointment and my aunt brought up the idea of home peritoneal dialysis herself, would they have listened to her? How much did bias play a role? So race-based patient outcome disparities have been described ad nauseum. In fact, if you poll most medical students, the punchline of Blacks, Hispanic, and Indigenous people have poorer outcomes than other groups is an expected phrase to hear in the discussion of almost any chronic disease. Research studies almost uniformly employ the variable of race as one of biologic significance. Dr. Francis Collins, however, arguably the mastermind behind the Human Genome Project himself, made it clear that we humans are essentially 99.9% identical in our genetic makeup. And the remaining 0.1% cannot be explained by our arbitrary designation of race. We know that race is a social construct. An ethnic group is not defined by physical or anthropomorphic features, which thankfully now is widely discredited as a definition of race, but rather describes a group of individuals with common geography, history, language, culture, and values. Yet despite this, we continue to conduct, to publish, and to fund studies that apply significant weight on what is likely a minimal biologic influence of race, and consistently fail to address the impact of what this social construct does enable, and that is racism and bias. I want to give you 2 quick examples of studies that highlight why this is important. We have a habit in research lumping all Latinx patients together despite their diverse ancestry. The term Hispanic is applied to people of Mexican, Puerto Rican, Cuban, Central and South American ancestry. In 2005, an interesting study which included 115 Latinx patients from Texas, from the Lumina Lupus study, and 613 Latin American mestizo patients from the Gladell study, a lupus study cohort, aimed to evaluate whether Amerindian ancestry could explain differences in outcomes between these 2 groups. They found that despite comparable ancestry and genetic background, similar disease activity, very similar treatment, Latinx patients in the US had poorer outcomes compared to their counterparts in Latin America. I'm going to say that one more time. Despite comparable ancestry, similar disease activity, similar treatment, Latinx patients in the US had poorer outcomes compared to their counterparts in Latin America. Another small study of about 130 consecutive patients with lupus kidney disease, all very similar disease activity, all provided the same treatment, found that the difference in outcomes between white and Black patients were eliminated when controlling for poverty and other socioeconomic factors. And I can pull up several more studies to demonstrate this point. So there are no less than 200 studies that are searchable under PubMed at this moment that report on race-based disparities in COVID-19. Many of these studies, though, fail to address the question of how much of these differences are explained or driven by the effects of structural racism. Rather than race playing a biologic role, race is likely a proxy of the social structures that lead to poverty, poor access to care, racism affecting the care that communities of color in many settings receive, and other factors. So as we're thinking about policies to help us implement anti-racist kidney care, we first need to interrogate how we are conducting the science that drives clinical practice. Research focused on race-based health disparities need to be held at higher standards, discouraging studies where race is solely evaluated as a biologic factor. Racism, which follows the social construct of race, must be evaluated or at least considered an important modifier of disease outcome. This tendency to use race as a biologic term is not only pervasive in health disparity studies, but has also permeated several clinical algorithms. The current hot button debate regarding the inclusion of race in GFR estimation equations and kidney transplant allocation is unfortunately modeling for the medical community at large our need to really interrogate the origins of the science regarding this practice. Now, the intent behind these contemporary algorithms certainly were to, at best as we can, approximate gold standard measurement data and improve access by creating a scalable, cost-effective method to follow patients and streamline care based upon sequential staging. Contemporary intent, however, may be overshadowed by the troubling history in which biased assertions have been propagated from generation to generation, tainting hypothesis-driven research, which our clinical practice relies on. All kidney health algorithms and policies that include race need to be reevaluated to interrogate the validity, the potential consequences of perpetuating disparities, largely unintended, and changed accordingly. In the story about the experience with my aunt, I mentioned that I couldn't help feel that bias played a role in her not being considered a candidate for home dialysis. It was not lost on me that her nephrologist was an older white male, and my aunt was an African-American woman with a high school education, modest income, living in a very rural town. Every last one of us harbors bias. It is often unconscious. Often it doesn't necessarily align with intent. Do I think that particular nephrologist wanted my aunt to have a poor quality of life? No. Do I think there were automatic assumptions that she would not be capable of managing home dialysis based on her education, low income status, and rural setting? Absolutely. Again, we all have bias. We owe it to our patients to not only acknowledge that, but also take steps to measure them and work hard to prevent their impact in our decision-making and conversations with our patients. Our ability to continue methodical, thoughtful conversations regarding bias and race in kidney health will tragically be hindered by policies stoked in the desire to disrupt any efforts to continue the progress we've made to directly tackle structural racism and implicit bias. Obstructive policies like the executive order in September entitled Combating Race and Sex Stereotyping has certainly posed a lot of concern for those of us working hard to address structural racism, unconscious bias, and social injustice. Many health societies have spoken out against this policy, including ASN, which poignantly stated that racial equity cannot be achieved without health equity, and health equity cannot be achieved without addressing systemic racism, implicit bias, and structural oppression. We also as a community need to support efforts that increase the diversity of our workforce. More than 50% of African Americans in the healthcare field today are trained in historically Black colleges and universities. You're currently listening to one of those individuals as we speak. These institutions need to not only be protected, but effectively partnered to enhance our workforce pipeline and the diversity. As bad as things are now, imagine how more devastating our fight against COVID-19 would be if we did not have the critical mass of international medical graduates that we have on the front lines of our hospitals. Policies that threaten the ability for these colleagues to train and practice in the US run the risk of absolutely crippling our critical nephrology workforce. And this goes well beyond our current fight of the COVID-19 pandemic. As we have heard many times over the last several months, and several of my colleagues on this panel have emphasized today, the COVID-19 pandemic has pulled the curtain back on the far-reaching effects of structural racism in this country. Discriminatory lending practices and inequity in school funding have effectively hindered communities of color from amassing generational wealth. Housing insecurity, food insecurity, as unemployment with job losses concentrated in low-paid industries increase, disproportionately affect communities of color. Rates of COVID-19 infection and mortality in these communities outpace others due to higher prevalence of multi-generational homes, higher likelihood of having public-facing jobs with inadequate PPE, lack of benefits or protections like sick leave, which paradoxically incentivizes people to come to work even if they're ill. These are all factors disproportionately affecting Black, Latinx, Indigenous, and immigrant communities. These factors are not unique to the patients in our nephrology community, but undoubtedly, given the overrepresentation of minorities affected by CKD, impacts our patients greatly. Contrary to the atrocities the COVID-19 pandemic has created, our eyes have been open to possibilities that a year ago, no one would anticipate we could massively upscale in such a short period of time. Telemedicine has without question mitigated what could have been an even more disastrous scenario where our ability to reach and care for our patients with routine care needs were greatly strained. In a society where mobile phones easily outnumber access to a car and other modes of transportation, telemedicine has been a welcomed lifeline for many. There's still a large segment, though, of our society, primarily in rural areas, left behind due to the digital divide. This divide not only hinders access to healthcare, but also impacts children, the pool of our future workforce, keeps people from working safely from home. And as this global society becomes more reliant on electronic communications, leaves a huge segment of our society at a disadvantage. It's difficult for people to apply for unemployment if they don't have access to a computer and the internet to file an application and track its submission. So in summary, as we think about the policies that will best help support anti-racist nephrology care, we first need to make sure that research focused on race-based health disparities are be held at a higher standard. We should be discouraging studies where race is evaluated solely as a biological factor and urging researchers to acknowledge and study the downstream effects of structural racism on patient outcomes. 2, all kidney health algorithms and policies that include race need to be reevaluated to interrogate their validity, potential consequences of perpetuating disparities, again, these largely unattended, and changed accordingly. We must denounce all actions to obstruct the education efforts in progress to fight structural racism and unconscious bias. Policies that support pipelines to increase diverse workforce and support contributions of international medical graduates must be championed. And lastly, as healthcare professionals, we have a responsibility to advocate for policies that will directly address social and structural factors that affect health, like transportation, housing, food insecurity, and the digital divide. This includes, but is not limited to, policies like Medicaid expansion, eliminating discriminatory practices like redlining, rethinking how our public schools are funded, promoting an increase in minimum wage to a true living wage, and access to the internet should be regarded as an essential utility akin to electricity and clean water. If we are bold and deliberate in our actions to push these policies, we may find ourselves much closer to solving race-based health disparities rather than simply describing them. Thank you. I'm happy to take any questions.
Okay, thank you so much. That was fabulous. We do have one question for you, and before we will go on to a summary and then the panel questions. So this comes from Amaka Ananya, and I'm sorry I pronounced her name incorrectly. Dr. Gibson, great talk. Given clinician and patient unawareness of racial disparities in home dialysis modalities, should institutions publicly report modality used by demographics?
Oh, that's a very great question. I am a true believer in measuring things. And as I'm thinking about the opportunity that we have in front of us with the new policies that are encouraging us to move renal replacement therapies back to home, getting more people transplanted. We're going to miss the boat, and we're going to leave people behind if we're not paying attention. So I do think that programs really need to make sure that they are taking some internal accounting to make sure that access to all forms of dialysis, that access to transplant are being tracked. That's the only way that we're going to figure out what the barriers are and hold ourselves accountable to make sure that we are not inadvertently imposing additional barriers to keep them from that.
Thank you. So before we move on to the panel questions and discussion section of the program, Jeff Perlmutter and I thank Dr. Nikki Laurie, Dr. Mary Klotman, Dr. Paul Klotman, and Dr. Keisha Gibson for their superb and illuminating presentations. Of course, I wish we, as I'm sure we all do, could have had this session in person, but it was still really wonderful. And thank you all to the speakers. The speakers covered a lot of territory this afternoon, providing us with insights into the impact of COVID on different aspects of our culture, institutions, and societies. Dr. Nikki Laurie, whose experiences at HHS and having overseen the federal public health response to a number of health crises, which gave her great insights and personal experience, provided us with perspective on the response to COVID with inside knowledge of how it was handled when New York was at its worst and dialysis supplies were scarce. Dr. Laurie covered areas such as leadership, the importance of local leaders, and that it's not just someone who's named a leader, but there was leadership of those on the front line as well who were caregivers. She talked about the strong day-to-day systems and the role that ASN played. She talked about how the kidney community has a good emergency response system, and told us about the emergency system that was put in place by Alan Kleiger, Jeff Silversweig, and Al Zickler, and the importance of communication within the network. She talked to us about the importance of safety and infection control systems that really allowed us to pivot, and also had us pushing the government to step up to the plate. She also addressed equity issues and talked about innovation. The Klotmans, through their own experiences at two different private institutions, put into context how academic health systems that traditionally have been guided by healthcare, research, and education as their core missions have stepped up to the plate and contributed so greatly to navigating the pandemic. They've also shown us how the innovation and expertise of the faculty have led to them filling in gaps locally, regionally, nationally in public health and policy. This has given this group a whole new level of influence and impact. And there's been really a new breed of celebrity, if you will, or perhaps better put, trusted sources of truth. But in taking on these expanded roles while coping with medical care during a pandemic, there's been tremendous stress on the academic health institutions and systems. Some of this work in these roles are unfunded, and in other countries may have been the purview of the government or other agencies. And finally, Dr. Keisha Gibson eloquently provided information regarding how the pandemic shed light on and also worsened the health disparities that are present in our society. She outlined how we should no longer study race as a biologic factor, but rather as a social construct. Dr. Gibson described the many areas of kidney health algorithms and policies that have included race areas to be re-examined. She made the point that we must stand against any pressure or actions that seek to undermine or obstruct educational efforts against racism and unconscious bias. And finally, she asked us to advocate for policies that will help those in our society whose health and access to health care is diminished by social and structural factors. Again, thank you, Dr. Laurie, Klotman, and Gibson. Let's now turn to questions for our fantastic speakers.
Thank you, Dr. Josephson, for that cogent summary of our talks. I guess I'll start with the asking of the questions. So to our questioners, some of these are rather complex, and I think we'll try to go in time order as to when they were asked, to be fair. So the first question comes from Kevin Fowler. Dr. Gibson, this is probably going to have to fall to you since you are the representative of the ASN on this panel, perhaps Dr. Josephson too. What are the plans for ASN? I'll ask, it's two parts. I'll ask the first part and then I'll give you the second part. What are the plans for ASN in 2021 to improve the early detection of kidney disease?
Yes. So we, as many of you are aware, make sure that am I muted? No, I'm not muted.
No, you're
yes.
on.
Yes, wonderful. As many of you are aware, the ASN has partnered with the National Kidney Foundation to create a task force that is vigilantly looking at this question, first with adding the race modifier to GFR estimation and all of the downstream effects from that. They are meeting very frequently, honestly, almost on a weekly basis. And we are anticipating initial information and direction from them before the end of the year. So it's an aggressive timeline. It's a very thoughtful group that has been put together of researchers, the patient voices represented, and leaders from both ASN and NKF.
Thank you. And the second part, can you provide a status update on patient activation as a CMS quality metric? And anyone can handle this who knows. But go ahead, Dr. Gibson.
Yeah, so I may have to get back to that individual to make sure that I give them the correct information. There's been a lot of activity. We know that many people have applied for the kidney care models, and announcements just recently went up. But I have not heard the final date for when we'll know about activation.
Right. So I can perhaps add a little of that. As people may or may not know, so patient activation is a major quality metric for the voluntary kidney care models, both Kidney Care First and for the kidney care entities. And I do not think that there's any plan that I've heard that will be removed. Those metrics are not going to change. There will likely be an addition of progression of kidney disease or slowing the progression that will come out at a later time, be added on. But as far as I know, the current measures metrics are in there and they include patient activation. Beyond that, I think we'd have to ask CMS if they have any plans, but not that I've heard. Any other thoughts from anyone else? Okay, I'll ask the next question. This comes from Dr. Lurie's close colleague, Dr. Silbersweig, if I heard her talk correctly. Everyone can answer, chime in. Few patients with end-stage kidney disease have enrolled in vaccine trials. How can we expand that number to ensure vaccines are safe for this population once approved, and I might add, efficacious as well? And the Klotmans, you can unmute.
So I'm happy to start with that if you like.
Go ahead.
Yeah, so I think that it needs to happen on a number of different levels. One is, I think it would be really important and probably really helpful even for ASN, the kidney community, to reach out to all the clinical trial sites. Many of them are at academic health centers, to talk to them about the importance of this and encourage this, and encourage dialysis providers to have their patients enroll in those trials, particularly if they are nearby. I mean, we just saw that the Moderna trial reached enrollment finally, but it had been delayed because it had a lot of difficulty with minority enrollment. That's not ESRD enrollment, but they finally got there. And that tells me that with some extra effort, that it is really possible to get there. Secondly, I think it's worth talking with the FDA about whether there ought to be any thresholds for minimal sample size for ESRD patient enrollment in subsequent trials, either as a criteria for EUA or as a criteria for licensure. As we may have with today's opportunity, the VRPAC, the Vaccine Advisory Committee, is meeting But there will, I think, be more opportunities, and I think some real advocacy would be important. And then third, not only the clinical trial sites, but the companies need to have a message about this loudly and clearly.
Dr. Gibson, would you like to address sort of level of comfort for people to participate in these trials?
Yeah, so I think, I really appreciated the earlier conversation about trust in science and trust in our providers. And certainly when we are looking at the challenges that we have in making sure that we have diverse representation in clinical trials, the trust between minority communities and the medical community, has been an issue. I cannot think of a moment in time that's more important than now, like with COVID-19, the importance of making sure that we're getting broad representation in trials. And so it's going to take us really working hard to encourage people to close the noise of the politicization around clinical trials, around COVID-19, in order for us to make progress. But I think the more that we get out there, Dr. Klothman made the point that the more that we infiltrate kind of the popular scene and the public gets to hear directly from us, I think that we will start to make some inroads in that regard.
Thanks. I'd like to add, from a practical standpoint, you have to bring the trial to the patients.
Absolutely.
It is way too much to ask dialysis, especially in-center patients, to have to travel to a site. Almost all of the clinical research that happens for dialysis patients happens in dialysis clinics. To ask people to go to sites to have additional blood work done, be stuck again when they're stuck 3 times a week is really, I think, quite burdensome, and it has to be considered as well. I'll hand it over to Dr. Josephson to continue our question asking.
Okay.
Just one other comment.
Go ahead. I'm sorry.
There have been sort of repeated opportunities to learn. And one thing that we did is listen to our community leaders, particularly around the reluctance to participate in vaccine trials and to really work in partnership. In other words, again, not have the university come in and say, just enroll, you're lucky to have this opportunity, but really work with community leadership. And the other thing we did is we set up a clinical trials unit in the community. We had never done that before. Everybody had to drive to the big health system, which is incredibly difficult to navigate. But because of COVID, because of listening to community, we set up a beautiful structure that is accessible to our community that will be used post-COVID. But we would probably not have done that unless we had this real need to be out there to enroll in the COVID trials. So we're learning from our experience.
Terrific. So the next question we have comes from Sri Lekha Tumalapalli. And again, I apologize if I mispronounce that. Health systems are increasingly purveying social services, e.g. housing, food. How can academic medical centers partner with community organizations and local governments to provide these services? How should financial risk be shared for adverse health outcomes?
You answer that one, Mary.
Well, they're 2 very different questions. So the first is really the partnership around all the other needs that many of the individuals that we provide care for have. And that's a tough one to own without these partnerships, right? And really trying to work closely with all the social service framework that we have to really build programs together. I think that academic institutions can't do it alone. They shouldn't be doing it alone. But again, developing these relationships, we know that all these other social determinants drive health. So I think what we're going to learn is eventually we do better as healthcare providers if we figure out how to better partner around these other social determinants of health. And some of the most passionate drivers of this partnership are students. I mean, they've been remarkable in terms of reminding us as an institution what other needs there are in the community that we need to work on. The other was the shared risk question. Was
It's how should financial risk be shared for adverse health outcomes?
it's such a broad question. Adverse outcomes in general, or Paul, you interpret that.
Yeah, so there are already models for that. The ACO models, capitated risk. You know, if you're on the line for the overall,
Yeah, but what are you doing?
then you are at risk. You are sharing risk. The fee-for-service model is not very conducive to a shared risk model. Although, you know, Blue Cross and all the Aetna, United, they are all creating a 3 to 5%, you know, quality potential gain. But I don't think we've solved that problem in the fee-for-service model. If you look at the VA, which is a capitated model, or our safety net hospitals, which are a capitated model, we are at risk. I mean, the more complications we have, the more money we lose. But in the fee-for-service model, it has not done well. I think the one thing that with the Obama care process did allow the ACOs to form, you know, back in the old days prior to that, doctors getting with hospitals to come up with a contract was called collusion. It's now considered an ACO. You can do shared risk modeling through an ACO kind of model, but it's not perfect for sure right now.
If I may interject, as kidney care is entering much more into risk-sharing models, the current pandemic brings up, I thought that's where this was sort of going. What does one do when something like this happens? You enter into a risk-sharing model, and then you get hit with a public health disaster that essentially completely destroys your ability to share the risk because the costs were unanticipated and can't possibly be covered by the entity. Dr. Klopman.
Yeah, I think we're, you know, this is a once in a century event, and you can see what's happening. It's put a giant dent in the health systems. They are not able to deal with this. That's what the CARES Act was for. We're getting bailouts because we are not able to deal with this kind of huge risk. There's no model that throws in a century-long pandemic and says deal with it. You know, this has been I mean, you could argue there is a reason for government, and this is where government needs to step in and provide support for our health systems.
Yeah, I can't agree with you more, but it's also really interesting and worth noting that the hospitals that work more on capitation models have actually done better in this pandemic. They have lost less, and it could really just be because there's so much less surgery and elective care and all of that sort of stuff. But it's not a foregone conclusion, you know, that everybody gets completely toasted, and that they've actually been willing to and able to shift resources because of their model to more outpatient care, to more of dealing with the social determinants in the situation.
The health systems have lost the most and the biggest margins. So it's the size of the margin that you have sort of dictated your loss. If you're surviving on Medicare, if you're a safety net hospital, you know, it wasn't much different because you weren't doing 500 cardiac caths and, you know, bypass surgeries. So COVID did expose the reality that if you're a high margin, you know, kind of institution, and all of a sudden you said you cannot do those procedures, well, you know, let COVID patients come in, then that was a big hit to those hospitals.
Deirdre Cruz just came back with an interpretation of the question, or a clarification, saying that he thinks that and probably the question was actually about shared financial risk of meeting social needs.
Yeah, that's what I thought. That's why I was, you know, trying to put it in that context. But that's a tough question, and particularly private institutions, which I think probably that question is different than for some of the public institutions.
I think you have to look at a community. How does a community manage risk? It's not each individual hospital. I mean, there's the VA system that does a great job. There's safety net hospital systems. There's private hospitals, children's hospitals. I don't think any single hospital can manage a community with. I think.
But she was talking about the other needs outside of direct delivery of care.
But doesn't that have so much to do, number one, with the payment model? Just as we were talking about, and you can't do this absent a payment model that supports it. But I think, Paul, I think you were onto something else that's really important. And I was so impressed with your discussion about the importance of data sharing and the fact that, historically hospitals in a community have just competed and competed and competed. They haven't wanted to share data. Even co-opetition is sort of a hard thing to get to in many cases. And, again, from my emergency management vantage point, it's been super challenging to get, all the hospitals sitting around a table, even to plan for disasters, let alone manage one. I think what you've seen now and what you've really been at the forefront in leading in your community, if it were extended to sharing data about other issues, including some of the ways that social determinants impact on your patients and their outcomes, you're really on a different path to having all of the healthcare institutions thinking about how to work together instead of in siloed stovepipes to start to impact on those determinants. And I would bet a fair amount of money that you can get a lot further working on those things together in a collaborative way than alone.
So you're exactly right. And I've already been interjecting, like, what about obesity here?
Yeah.
And what about diabetes? We could do a lot if we simply begin to share best practices. And because of COVID, they're actually interested because it is a community problem, that's a problem for everybody. And we've done a model where we've actually been willing to share data. The exchanges, again, the Obamacare next step was the exchanges of information. That was really to help patients navigate multiple hospitals. But if you do it right, you can make it a way for us to share, exchange information around dealing with problems too.
Yeah.
And I hope that's what happens.
Yeah, and now the GIS technology is such too that as you map them and you look at where you've got shared market share, shared workforce, I mean, all of these hospitals also have a pretty substantial low-income workforce challenged by these same determinants, and it's going to be in everybody's interests.
Well, Nicole, you're absolutely right, and that's
to deal with them. Yeah.
Another lesson is that the health of our workforce is critical. And it was during COVID that has been, a focus like we've never seen before, because as our workforce started to get sick, all of a sudden we couldn't care for the patients. So the focus shifted to keeping our workforce healthy. So it's really how you align incentives, right?
Yeah.
So I just actually the original questioner sent in their what they meant. So I'll tell you what they meant, and then we'll go to the next question. What they said is, thank you for your responses. My meaning behind the question was, we know social determinants of health influence healthcare utilization, and the health systems are being penalized for this. Should community organizations share some of the financial risk? That was what they meant. So yeah. I don't know if there's a comment. Go ahead if there's.
No, but I mean, it's interesting. Did they say the health system was being penalized or the people were being penalized?
They said and health systems are being penalized.
The health systems in fee for service do well when the population's sick. I mean, that's the perverse problem.
That's right.
We want to cure diabetes and end-stage renal disease because it's the right thing to do. Do dialysis doctors want to do that? I mean, yes, in theory.
Jeff saying yes.
Sure. Well, that's because he's at the end of his career. But the fact of the matter is, if you're a high acuity hospital, if you're dealing with complexity, you look at the volumes in a capitated environment like the VA hospital, how many casts are done versus how many are done in a fee for service. And it just, as Nicole had said, it's the payment model. So, the payment model has to change to really affect some of these utilization around issues related to health and health disparities. I mean, the payment model's got to change.
So getting back a little bit to the issue of workforce and also to trainees, we have actually a question from a fellow, and this comes from Sid Bajrachara. Yeah, and I'm sorry again if I have really macerated your name, but I'm sorry about that. But what do you see as the role of trainees in nephrology during this kind of crisis? How do you balance service, safety, education, and fair treatment for trainees, such as hazard pay, for example? So let me ask the panel what they think.
Good question. So let me change the question. All of us who have medical schools had a big problem because AAMC said the first thing you need to do is get the learners away, to protect them off the wards. And I'm sitting there going, wait a minute, we have a once in a lifetime global pandemic, and we've got to learn how to, deal with it. We want our medical school students involved. I mean, this is why we all went into healthcare. And so I was pleased and lobbied very heavily that the AAMC changed that. And we were able to get medical students back on after we figured out ways to keep them safe. If you're a trainee and you're dealing with a health crisis, and we've been through, Mary and I started with HIV, and let's go through MERS and SARS, and yes, you want to protect people. You don't want to send people in uneducated and unable. But if you go into healthcare, to me, and you're in the delivery side of healthcare, which most nephrologists are, you got to go in there and take care of people. We want to make it safe, and we've got to make it reasonable. We want to make you aware, but I'm not sure, unless you have diabetes or asthma, or you're over 60, unless you have all these preconditions that we now know put you at greater risk. I don't see how you protect people from being physicians. That's just my own, or maybe it's because I'm old.
Yeah. After the original, I agree that AAMC, I thought, acted a little bit prematurely on that the first month or so, and we all were very anxious to get our students back into the clinical setting under safe conditions. But I have seen them the same as I see residents, as I see our nurses, as I see our providers, that the obligation is to provide as safe of environment for all of our healthcare team to work in, including environmental services. It's not unique to any part of our workforce. The hazard pay, I mean, again, that to me is a question, does everybody get hazard pay? Not just residents, not just nurses, and I think that's up for debate, but I tend to agree with Paul. There are so many hazards in the health profession that I think the obligation is to keep the working environment as safe as we can, no matter what comes our way, whether it's TB or it's COVID or needle sticks or anything else.
It was hepatitis B when I was trained.
So because you're old and I'm old, I mean, we all think about the fact that we all took care of and had these same debates, when HIV first came on the scene. And there was a scary new disease. None of us really knew what it was. For a long time, we couldn't test it. And I think all of us then as students and residents, right, struggled with these same issues and these same questions. And there were lots of geographic differences and lots of political discussion. But it was really an important part of the discussion about what professionalism was and what our obligations were as physicians and as a healthcare workforce. And, I think we do a huge disservice to learners by not having them not helping them grapple with those same sets of issues, while obviously doing everything we can do to keep them and everybody else as safe as possible. One of the the things I've appreciated about their advocacy, and it sort of gets into my mind, expressed sometimes as hazard pay is, gosh, you could do a whole lot better job with safety. You could do a whole lot better job with working conditions. Our government needs to do a whole much better job making sure we have PPE, all of those things. And to channel that kind of advocacy to really making it better for everybody.
Yeah, but I think historically, whenever we've seen major movements and change in how we deliver healthcare, the energy, the enthusiasm of our trainees that are coming in, has really always been at the front of it. I mean, they've been the change agents. And if we don't do a good job of making sure that they are part of this process, I think that we really do take away, that additional value that they add to our academic environments.
I want to say one other thing, which is, may not make sense, but when we first had the students off the wards, they were angry and they were upset because they were excluded from being healthcare participants in a major problem. And if we made a rule like, oh, all fellows and trainees can, you don't take care of COVID patients, go home, don't worry about it, I don't think that would go over well. So I think you have to realize that the vast majority of the people who go into the field of medicine who are in the delivery side want to be there. And it's, as Mary said, I think our responsibility is to make it as safe as possible, give them the information they need. And if someone comes to me and said, like, I have issues, I don't want to do this, fine, you can opt out. I think, but I don't think people get hazard pay, but you have to give people an opportunity if they really feel uncomfortable. I mean, you really, don't want to do this. You don't want to force them either. So I do think you have to give people an opportunity to find another way to contribute. We had diabetic students, and what we did was put them on a call center, answering questions. We said, you probably shouldn't be taking the risk. Type 1 diabetic probably shouldn't be there. We have type 1 diabetics or anesthesiologists on our, on our faculty. I said, you know what, probably shouldn't be intubating people, but we found other things for them to do. But I wouldn't have said, look, no one goes in. That's just not fair to the trainee. I mean, people forget it's not fair to the trainees who want to actually participate.
All this being said, we were not a hospital that ran out of equipment. And didn't put our providers in situations where they weren't safe. But I think that was the reality in a number of hospitals. And again, that just really focuses the effort should be on letting that never happen again. And that's, everything from understanding supply side to our hospitals to developing, real strict policies about what is or is not acceptable and in the environment that we put our providers.
Thank you. Jeff, do you want to take the next few questions?
Okay. So to our questioners, I just want to remind you we're going by time the question is received. And this has been such a robust discussion. We are not going to get to all of your questions. We have 7 minutes left. The next two are to specifically to the Klopmans. First one is, what projects are your institutions pursuing to track and assess COVID-19 long-haul patients, as well as how these patients are affecting the larger community? Go ahead.
So, I mean, our research focus on COVID has just been phenomenal. And so we do have several cohorts that we're following. Actually, fortunately or not, we had an early cohort that was identified within the first month. And that cohort now is a longitudinal cohort where we're following both their physical and their long-term potential symptoms, but also did a lot of virologic longitudinal studies. So those kind of cohort studies are going to be really important, and they need to be followed for months, if not years, because we really do not understand what the longer-term outcomes of this virus are. And the more we are learning, the more there is evidence that there's multi-system outcomes. So we've set up the cohorts. We've set them up in pediatrics. We've set them up in otherwise healthy adults. We've set them up in some of our acute care patients that have been discharged. So we just really need to study them.
I would say that we don't have a national strategy around this at all. For us, and I think for Mary too, it's investigator initiated. We're a genome center, so we're sequencing everybody. We sequence all the viruses. And we have a very strong group in pulmonary medicine that's following, sort of longitudinally, complications. We have a group in cardiology that's looking at cardiac risk. But I think it would be much smarter for probably an NIH-sponsored multi-institutional trial to guide long-term strategy, much as they did in the Top Med program, where took 20,000 cardiovascular risk patients. I think the NIDDK ought to probably do something around chronic, following renal patients. That's got to be, I think, those cohorts have to be driven by a funding agency.
I agree.
So I might just jump in here, because I think for me, one of the many, but one of the major failings of government here has been sort of outside of developing vaccines and late to the game in trialing, taking responsibility for trialing therapeutics, has been taking any responsibility for helping develop evidence about how to care for people, about how to keep people alive, about now how to deal with these long haulers. And you have thousands of clinicians on Project Echo calls every week sharing their clinical experience, and no way right now to turn clinical experience into evidence. And, just this conversation is making me wonder whether here we have, leaders of two premier academic institutions. We have many of you on the phone. Is there a way to channel your leadership wherever you are to really think about, could we push the federal government not only to have a registry and not only to start looking at the kinds of things that we're seeing in these long haul patients around the country, but turning that work into various clinical trials about clinical care. It doesn't always have to be about a product, but gosh, we got to develop evidence about how to take care of these people.
Well, the challenge has got to be good evidence, right? And the data has to be standardized data. But I think the whole movement,
have some RCTs.
Yeah, but the whole movement to really standardize across health systems, I think, is a very positive movement. I sat on a call that Amy Abernathy was on the other night, the deputy director of the FDA, where it was all about how can we, using COVID as our experience, really understand using real world data as a platform to really understand both care and therapeutics. Now, therapeutics, I think it's real tough. We've seen a lot of mistakes there.
Right, and this epidemic has shown us already that real data is not good enough.
Yeah. But so health system randomized controlled trials, that PCORI is supposed to be one of those platforms to be able to do that. It's been a challenge.
And related to this issue, and you touched on it before, from Glenda Roberts, any particular issues with patient privacy in the context of COVID-19?
Yeah, I think one of the things we've been trying to do is when we start looking at outcomes, just like we're talking about, and follow-up, everything requires IRB approval, and we really struggle a lot of times with trying to take all these data sets that we have with all these thousands of patients. We don't have a universal IRB, and so while we can follow demographics, we can't follow outcomes as much as we'd like to. So I think we all struggle. We're in the middle of managing a pandemic, and so not everybody's thinking about how do we do a randomized clinical trial to get it going. So I think we're just struggling. We're all very busy managing our own little crises on a daily basis, but we need a better solution, I think, for this kind of outcome, following patients that we just haven't figured out yet.
And the challenges of privacy is not only in following patients, it's how we've managed contact tracing. We know there are probably very innovative solutions there, but they tend to go over the line of privacy, particularly in terms of cell phone data information. And we had quite an interesting discussion with our faculty because we wanted to use cell phone data on our campus if there was an index case to be able to really precisely say in what room and who came in contact. That's a privacy issue that most people are not willing to go over that line. So it's raised a lot of interesting questions in terms of what people are willing to give up to have better systems. And I think contact tracing is one of those areas where we know there are better solutions.
The hour is late. I want to thank my co-moderator, the panel participants, and those who provided questions for an excellent, wonderful session. There are actually some really terrific questions sitting out here. Unfortunately, it might take us another hour to answer them all, given some of the issues that surround them. I don't know the answer to this. If we can get them answered for you all, if there's a way to save these questions and get them answered, we will provide the answers. I'd like to answer a couple of myself, but for right now, we'll have to hold off. And I wish you all good evening, good afternoon, whatever part of the country you're in. Again, thank you to all the panelists, and we'll see you in the virtual world tomorrow. Good night.
Cool.
Right. Thank you.